is rapid sequence induction? He's mashallah first year resident. A very good question comes in her mind. So please just try to tell in few seconds what is rapid sequence induction.
uh, in which we use short-acting muscle relaxant,
Okay.
and we apply cricoid pressure,
Okay.
and um, um, pre-oxygenation. We
Very
don't
good.
do pre-oxygenation.
No, we do pre-oxygenation. We do pre-oxygenation, but we don't ventilate.
Okay.
Okay. So, like you are using pre-calculated doses, you are using suxamethonium, you are doing pre-oxygenation, and you are doing cricoid pressure, and but you don't ventilate. Okay. So this is what we do. So any modification in it, it will be modified rapid sequence induction. Like in place of suxamethonium, you are using rocuronium. In place of no ventilation, you are doing shallow breaths with pressure less than 15. Okay.
Okay.
So that will become modified rapid sequence induction. The problems with rapid sequence induction is that the patients who are at risk of swings of blood pressure which occurs, for example, in elderly patient or any patient with autonomic neuropathy. Okay, if you gave a pre-calculated doses, there is a chance that the patient will become too much hypotensive. Okay, so it can create a problem itself. Okay, so this is one explanation. The other explanation is that if the concept of modified rapid sequence reduction is also parallel with the presence of sugammadex. Okay, because rocuronium, there is a reversal, immediate antidote, which can reverse the effect of rocuronium in case you are not able to intubate. Okay, there is no immediate reversal of suxamethonium. Okay, so if you give suxamethonium, you don't know whether there is chances of suxamethonium apnea. Okay, so sux apnea can be there. So if the advantage is this, so you are using a high dose of rocuronium around 1.2 milligram per kg, the effect will come within 60 to 90 seconds. You
90
don't need
seconds.
you don't need to ventilate, and still, or if you want to ventilate, you can use a better technique, and you can ventilate the patient even with the help of ventilator, setting a set pressure. Okay, so it will be giving a set pressure, and you are not over inflating or giving excessive airway pressure, which is opening the wrong or haram door of esophagus and air
Esophagus.
going in the stomach. So this is the concept. Okay,
And what
so
do you mean by pre-calculated doses?
pre-calculated doses means you are, for example, you are saying that this is 70 kg, so you are giving, you are not otherwise the best way is to give us no no we I will be opening the screen, Dr. Juliet. I will be opening the screen shortly. Okay, just a second, let me open it for you. Sorry. So pre-calculated doses means that if, for example, you are for example, you are saying that you are using 100 milligram of suxamethonium and 200 milligram of propofol. So you don't wait. Otherwise, the best way is to go slowly and see the response.
Yes.
Okay. So what is now we are discussing. So let us finish this small few points as well. What is the way to check? What is the way to check out the response of propofol? Like when will we say that the patient is gone? It is do Heppel command. Okay. Please, all of you are requested to mute. Okay. So the response to propofol is seen by doing verbal communication. Okay, and there was a
Yes.
medication which was there, and actually that is the ideal agent for, I will have to I will have to remove this person. He is disturbing everyone. Sorry, sorry for the interruption. Anyways, so if you are using propofol, to know that the effect has come, the command is verbal command. Okay, the patient is not responding to your command. This is with propofol. And the actually the ideal agent for rapid sequence induction, which you people are not using it, is thiopentone. Okay, it may be available in some part of the world, but actually the fastest induction is through thiopentone, which is also called sodium thiopental. Or so it is said that arm to brain distance, arm to, I can write it if someone is, arm to brain time is the shortest. Okay, so but because of you can say the monopoly of pharmaceutical companies, propofol companies, they actually bought thiopentone salt in most part of the world and finished it. Though thiopentone is still a very good medication in, for example, for instance, if you say for rapid sequence reduction, actually sodium thiopentol is the best, but it's not available now. It has anti-epileptic effect more than propofol. Okay, so that is the advantage of asking questions. Though if you ask the question, so many people listen to it. Actually, so now we will be starting the topic which I am, because there is an exam in recent in near future. So my focus is to give that those people chance to uh, have a review of the main topics which are being asked in the exam. Majority of topics I have had discussed before as well. And so if you people just go to the this YouTube channel, you can find in the playlists. Just a second. Okay, so this is the YouTube channel. And if you go to the playlist, for example, for instance, for pediatrics, uh, I will just show you. Yes, this is around 17 videos. Not actually, before I don't used to have this discussion in English. So some of them are not in English, but since last 6 months, they all are in English. This is one thing. And before I was not very well familiar in sharing the screen and doing something. So unfortunately, this I actually in this 6 or 7, I have discussed almost all of the pediatric anesthesia before. Okay. So today I will be just trying to repeat it in a quick way. And in the same way, we will start. Okay. So Mamuna, I hope your mic is good today. Mamuna, can you listen? Am I audible to you? Okay.
Hello, Assalamu alaikum, sir. Sorry,
Walaikum salam.
yes.
Yes. Okay.
I'm
So
at a
just
good
like,
place, but yes, I
yes,
think so. I
hopefully,
am
inshallah.
audible.
Just like we did yesterday. So we have a pediatric patient, okay, around 4 years, for example. So you are undergoing any surgery. To start with, we will do in the similar fashion like we did yesterday. What will be the logistics? Different. What will be your planning? You have the surgeon told you, or our staff told you, we are having a 4-year-old child. So what will be the special things you will be thinking? Yes, please.
In this 4 years old kid, I will divide my management plan in pre-operative, intraoperative, and post-operative category. So pre-operatively, there is a chance of stranger anxiety and the parental
Okay.
separation.
So
So
anxiolysis.
yes,
Anxiolysis, one thing. Okay. Other thing,
and to get an venous access, because
IV
it
line.
will
Very good.
can be
Then
and of course
calculate
ruling, yes,
medications and equipment.
equipments in the intraop, and of course the specialized OT, because we
OR
cannot
environment,
shift the preparation from one to the other, in like if the OR head staff says
especially
that we are not.
temperature,
Temperature,
ventilator.
yes, I will turn off the AC or air conditioning, and preset a ventilator tidal volume, and
Just for
airway volume.
instance, just for instance, what will be the optimal temperature for pediatrics?
uh, 28 to 32 degrees
26
No.
Celsius.
Surgeon will kick
26.
you out. If you make 32, surgeon will kick you out, believe me. Because surgeons
Uh,
are wearing so much things. I think it is
24.
26,
No,
25 to
26.
26. Reconfirm it. Because I
okay.
am very bad in memorizing the numbers. I think it is 25, 26. Unfortunately, practically nobody does it. Practically nobody does it. So if, for example, room temperature is not good, there are other ways to control this thing.
Yes,
What are the other ways?
I was talking about that before induction. When I will do the induction and I will have the gadgets to maintain the normothermia, then of course they can maintain the temperature whatever they want. Like if I have bear hunger and I can maintain the body temperature, head cover, I will plan all these things accordingly during after induction, of course.
सर
Yes, there is
हेड कवर
warming.
करेंगे कि बेबी का जो फोर्स्ट एयर वार्मिंग ब्लैंकेट डाल सकते हैं अगर उसकी टांगों पे
Dr. Mona, sorry to interrupt you. Try to speak in English. We have some international speakers, international audience. Okay, so just try to communicate in English.
cover the head of
Yes,
the baby
we can put
use the
blanket. We can
हाँ
put there is a special
warm
mattress,
yes
bed mattress. Okay, so for temperature, actually, we are not following a specific book. We are trying to understand. Then when we understand, then you can put this knowledge wherever it's being asked. So for temperature, I just targeted temperature problems and this
Yes.
go. So ideally the temperature should be maintained. Then the other things will be warming blankets, warm fluids, head cover, bed mattress, and everything. Okay.
And
So related to
regarding
yes.
induction, if there is usually there is we do the inhalational induction if it is elective, and after inhalational induction we get venous access if the patient
Okay.
baby is not cooperating.
Okay, just a second, just a second. For regarding, we will just discuss about IV lines. So
Yes, venous
what are
access.
different ways to handle it? Have you heard of Amla cream?
Yes,
What
we
is
don't have
Amla?
in our setup here.
Of course, this is just like stories of heaven. Okay, so Amla, what is Amla?
It is the combination of the
Eutectic
lidocaine
mixture
or local
of
anesthetic.
local anesthetics. Okay, so
2%
you
lignocaine and 2% prilocaine
prilocaine and lignocaine. Okay, so just for brainstorming, what is the problem related to prilocaine?
Methemoglobinemia,
Methemoglobinemia. How to
which is
treat
well,
methemoglobinemia? Methylene blue.
yes,
So
antidote.
actually, this is the message for the junior residents as well. Try to read like this. Don't move forward. Stay like a, believe me, sometimes I am giving you a very odd example. Become like a donkey. Don't move till the time the person standing next hit, just like that, till the time you don't understand the words. Don't move forward. If you understand, like if you read like this, believe me, you will have, at the end of the day, you will have so much knowledge that nobody can catch your neck. Okay, so for example, because what happens in the exam, you use the word Amla and you don't know about Amla, the examiner can't ask you what is Amla. Then you don't know what is Amla and then they will fail you. Okay, so this is why it is important. So how to use Amla? You need at least 30 minutes. Okay, 15 to, if I'm not wrong, 15 to 30 minutes.
Yes.
Put it in the area where you find the IV lines and then you cover it. Let that effects take effect and then you can try IV line. Okay, this is one way with the help of Amla. What else? You told about inhalational induction. Okay, any
Yes.
other way? Any other way you can do? So you can do some anxiolysis by,
Mm.
what are the different
Why
ways for anxiolysis?
intramuscular, intranasal,
Ketamine,
even oral? Yes.
oral. There are like internationally, there are some fentanyl lollipops.
Polypops. Yes.
Okay, you can you put some medications rectally as well?
Yes.
Rectal
In benzodiazepine.
suppositories. Okay, then
Yes.
what else? Anything else?
Intranasal. Intranasal.
Intranasal.
We
Okay.
use yes.
So you know in some hospitals they have because there is a concept of preemptive analgesia. So for
Yes.
preemptive analgesia they are using paracetamol. Okay. So they add midazolam. Okay. So paracetamol is usually cherry flavored. It's a tasty. So they made a very pathetic taste midazolam in it, and they give the baby. Okay. And actually this is
Okay, it's
quite high dose.
suspension form.
Yes, they
Okay.
sometimes it's a very high dose, 0.5 milligram up to 0.5 milligram per kg of midazolam. Okay, so this is one option that they intramuscular ketamine is another option. When you are giving intramuscular ketamine, do you have any consideration? A baby will
Um,
cry with the needle.
yes.
This is one thing, and another thing is secretions can increase. Okay, so you have to anticipate it, and might be you need glycopyrrolate or atropine. Okay,
Mm.
so this is another thing you should be knowing. So I think these are okay. So some bad and invasive ways. What are those? Okay, so intraosseous. Okay, and use of ultrasound or vein visualizer. Okay, I think Memuna, you can unmute yourself. Anyone else want to participate? Please, Dr. Mona, if you want to participate, you are welcome. Just raise the hand. Anyone wants to speak out, just raise the hand. Okay, so I think these are the options for IV. So similar in the same, we will just think about the anzolysis. It's in anzolysis, we discuss some of the options. Okay. And another, this is just for your knowledge that in some
Non-pharmacological anxiolysis sort of.
anzul,
Uh,
what are different options that actually in some part of the world, and this is just for your information, don't, because you won't have time to speak out these things in our exam. So but in some part of the world there is mock or like for kids to familiarize. Okay, where they have just created a place where they in the pre-operative part time that they are visiting, and even they have special mask with, I have seen, is just why it's my luck that I have seen cherry flavored or lemon flavored or things like that. There are masks which are uh, having this taste. Okay, so when you put the mask for inhalation reduction, actually they are not afraid of it. Okay, and another thing is that you can give the bag, and they ask them to use it like a balloon. Okay, so when you are using sevoflurane, it should it should get the effect very quickly with 1 or 2 full vital capacity breaths, 3 to 4 vital capacity breaths, baby will be slept. Okay, so these are just for your knowledge. These are the things to handle it. Another way is to take the parents. In some hospitals, they will allow the parents to cover properly and go with the patient inside. In today 2020, mobile is another way. Okay, to counteract these things. Anyways, so what about the equipment? Equipment will be challenging regarding airway, for example, appropriate
laryngoscope plate. Yes,
laryngoscope blades.
appropriate size. We can start from machine. We have to change the. We need TPs. We need
TPs.
different.
Okay, just a second. I will, because I will tell you something. What about pressure control versus volume control, especially in peds population. So volume control, it is better to use pressure control. Okay, TPs actually, yes, of course, we are using it, but if you have advanced ventilators, there is no need for TPs. Okay, if you have good ventilators, actually, there are special circuits, so no need for TPs. Only TPs is there if you are having the not that much developed equipment. Okay, so practically it's not being used. Yes, in the exam you can say this. So pressure
Okay,
control
so
versus pressure control will be a better option. What else? Laryngoscope. What about
yes,
what is the straight?
laryngoscope and the specialized ambu bag for pediatric ambu bag
Okay,
in
low
the
volume,
airway trolley.
small ambu bag.
Straight blade, which is called if I'm not
Don't worry.
able to
If you forget, don't worry. Um,
so
what
different
else?
size of blades, different
Mhm.
size of pediatric masks, different shapes of pediatric masks, oropharyngeal airway, smaller size of LMA, igel.
Would you like to use
Because
nasopharyngeal airway in pediatrics?
not really,
Why?
because they have narrow passages and they
Adenoids.
are more
There are chances
yes.
of having
So
adenoids. Okay.
yes. So
So
basically, I'm trying to say that the pediatric population is having anticipated difficult airway always, and
yes.
there is the high
Okay.
risk
Okay.
of
Just a second.
airway complications.
Just a second. So now we will just discuss the third word which you have said. What is the reason for anticipated difficult airway in pediatrics? What is the reason?
Um, I can divide my answer into two categories: anatomical causes, anatomical differences, and physiological differences.
Okay.
If I
Okay.
Yes, if I will start from the anatomical causes, they have prominent occiput, so problem with the positioning, and they have narrow passages, airway passages. There is high airway resistance, and they have large tongue, so they are more prone to airway obstruction.
Okay.
They have smaller oral airway cavity, so we need smaller airway gadgets and smaller ETT size and LMA everything. Regarding laryngoscopy and in the glottis area, they have the omega shaped large size epiglottis, and they have narrow trachea and the fragile tracheal cartilages.
Another thing regarding this, just you have missed a few things. They have narrowest point is cricoid cartilage. Okay. So it's a funnel shape. It's a funnel shape airway. So tube may pass through the glottis, but there is
And
infraglottic.
stuck with the adenoids.
So cricoid cartilage is the narrowest point. So tube can stuck. That's why you don't need to push too hard. This is one thing.
Yes, sir.
Then you told about.
Larynx larynx is
Sorry,
superior and anterior.
I'm sorry.
Sir, larynx is located more anteriorly and superiorly.
Yes, anterior larynx. Okay. So the for counteracting it, you may need to put something under the head just to make the view better. That's why which we discussed the oral, the pharyngeal, and the laryngeal angles to be aligned. Okay.
So
So
the positioning of cords is also different from the adult population, right? If I'm not wrong, cords are more horizontal.
I don't know. Actually, this is not very important thing. Maybe it's
In
there. I cannot recall.
adults, cords
Okay.
are oblique. Memona, cords are oblique. In adults, they are horizontal.
Okay.
Okay, so the more important thing is that the tube may pass through the cricoid cartilage, sorry, through the vocal cord, but it's stuck in cricoid. Okay, so you have to keep the airway pressures. You have to monitor. So better mode will be pressure control ventilation, and you because the mask, proper mask, and it can damage the eyes and nose cartilage if you don't press too much. Okay.
Yes, and
So
they are very they have high minute ventilation, and they are very prone to desaturation. So this
just a
and
second.
if we
No,
will
no,
okay,
just a second. Just correct yourself. High minute ventilation or high oxygen
and
consumption.
oxygenation consumption. Yes,
High oxygen consumption and low FRC.
yes, low FRC.
They have low FRC because of Less
So they have
developed,
inclined chest, less developed alveoli.
just developed respiratory mechanics. Okay, they have horizontal ribs. Okay, so and their alveoli are relatively fragile. Okay, compliance is less, they are less compliant relatively. This will be different in actually not really in 4 years. It will be different in different age group landmarks, but generally you can recall by these things. Okay, so that's why oxygen consumption is more. If someone can tell the number, I forget always. It is, I think, 7 to 8 ml per kg, if I'm not
Yes,
wrong,
sir. Yes, sir.
per minute. Okay, so in adults it is 3 to 4, I think. Okay,
Yes.
so it is this. So you have less store, and you are like you have less amount in your bank account, and you are using too much. So that is the concept. Okay, so in addition, like making this airway and respiratory system make more complicated, the patient can is prone to become hypoxic early. Okay, and now if you just correlate these things, usually when there is hypoxia, what happens in any adult, for example? Sympathetic stimulation. Okay,
Yes,
so
they don't have developed sympathetic
they don't
system,
have
so they have,
developed chemoreceptor and baroreceptor responses.
so
Okay,
they will lead to bradycardia,
so
early
and then
cardiac.
we just correlate this thing further, that there is cardiac output is heart rate dependent. Okay,
Yes, fixed cardiac
so
output
that's why hypoxia
due to
becomes a,
non-compliant.
yes. So hypoxia, if you don't treat hypoxia quickly, patient can have cardiac arrest. Okay, so usually the reason for cardiac arrest or even any hemodynamic compromise is usually hypoxia. So that's why
Hypoxia
hypoxia is
leading cause.
very important to consider. Okay, so because there is in you they have less compliant left ventricle. Okay, they have fixed sort of cardiac output. They cannot change cardiac output according to the need. Okay, so I think if anyone can tell anything about the airway in pediatrics, anything we missed, we will just go to the some article as well to just see what if we missed anything. So, but I think the more important thing we have already covered. So up till now,
Dr. Zishan, you said that to align the oropharyngeal and axis, we put something under the head, but in pediatrics, the head is already larger than the size of the
not under,
body.
actually no,
So,
maybe just under the neck. Maybe I use,
yes.
okay.
Okay. Okay.
Okay, so oropharyngeal angle you will correct like that. Okay, so up till now we have discussed about IV lines, anxiolysis, okay, temperature, and then we discuss about the airway. Now, if we just discuss about the medications, so
Sir,
what
one
is,
thing I would like to add in the airway of pediatric
yes,
population, sir.
yes.
Sir, they have delicate mucosa and delicate structures, so they are more prone during manipulation of airway anatomy. They are more prone to airway obstruction or any sort of edema.
Yes.
Careful handling of the airway, yes, is
Yes,
important.
actually, I forgot one thing, so I will, you just recall, thanks for recalling. The concept of cuffed versus uncuffed. Cuffed versus uncuffed endotracheal tubes.
Yes.
So what is the concept for it?
There is in the literature that the uncuffed tube should not be used under
Should
the
not be used.
in the less than 12 years. I think so, I'm not wrong.
You said
8 to
uncuffed.
12 years.
Cuffed.
Cuffed EDT should not be used under 8 to 12
This was
years of
actually,
age.
this is old concept. Okay,
Old
there are
concept.
some advantages and disadvantages. If you are, or theoretically, that's the same reason that their mucosa is very fragile. I don't know where it goes. Just a second. Okay, so mucosa is fragile and this and that. but the same thing for which you are using endotracheal tube, it's not properly fixed, dislodgement, aspiration will not be prevented. So these are the things that now, because what was the main problem? Problem was high pressure. Okay,
High pressure cuff.
high pressure cuff. So now we have low pressure cuffs. Okay. The endotracheal tube we have is high volume, low pressure. Okay. So how much should be the pressure? What is the reason for this pressure? What is the pressure limit for it?
So tracheal capillaries has a pressure of 30 centimeter of water. So we have to keep the pressure of the ETT cuff lower than 30 centimeter.
Yes, I think
25
that
is the
is
range.
slightly higher. It is less than
20 to
20.
25 is.
I
yes,
think
it's the
25 you
range.
have to, and how to monitor this pressure? How can you tell that this pressure is like this? There is manometers.
Sir, via manometry.
Yes,
Yes,
there is
to
manometer.
attach this cuff manometer.
Okay, if you don't have manometer, what can you do?
We can place air as low as possible. So after induction, I will remove the air from the cuff, and where the leak comes, I will
Yes, you
inflate.
can do with the air leak. Okay.
Yes, air leak test. Yes.
Air leak test. So if, for example, you have passed uncuffed tube and you have any risk of aspiration or bleeding, what you will do? You will put a small throat pack.
Throat pack. Yes.
Okay. So what are now still, because that's the beauty of learning in this way. You will create questions for yourself. What are concerns related to throat pack?
So throat pad can be left behind and it can cause
During
another
placement,
chaos.
we
No,
can
just let him
divide
talk.
it.
Let him talk. You have to announce
sorry,
that throat
sir.
pack is in. You have to put, you can attach it at the end to the side of the mouth. Okay, so that you don't forget. And if it is, for example, retained, it can cause obstruction. That's why you have to use the radio opaque. There is a line on it, on the throat pack. And when you are putting the throat pack, you should lubricate it nicely. Okay. You should lubricate it nicely, and you should not put it blindly. You should put it under vision. Under vision, and as much as required. Don't put it too much, because it will cause severe sore throat. Okay. So these are few, because actually the things which some people encounter, don't forget. There was a question in FRC exam only on throat pack. What are the concerns related to throat pack? Okay. So this is
So you said that we announce and we will
announce
document on
means
our performer
announce
as
means
well.
the nursing staff, you should say throat pack in, and then we remove
Yes.
it, throat pack out, and they will write it on the board. Okay.
Yes, and we will write on our performer for medical legal purpose as well.
So that we don't forget. Okay. So these are some issues related to cuff, and you, as we discussed, that it should be the less than the capillary pressure. Okay, because otherwise it will cause necrosis, and it will be cause of subglottic edema. Okay, so we already said that there is subglottic narrowing in pediatric population. So if the lumen is further blocked, okay, it will be becoming obstruction. Okay, so that is why subglottic edema is a serious problem. So how to treat subglottic edema if it occurs?
Sir, via inhalational agents or bronchodilator agents or steroid therapy.
No, just a second.
Anti-inflammatory.
Just a second. Who was talking, please? TAK, you were talking?
Sir.
Yes. So just correct yourself. You said bronchodilators. So what will bronchodilators do?
So they will dilate
No.
the bronchioles.
No. So this is subglottic. This is trachea,
Yes.
not
Yes, sir.
bronchus. So here
Yes.
you need steroids. Okay.
Yes, steroids and
And
epinephrine.
need
Yes.
what else? Adrenaline.
Adrenaline. Yes.
Adrenaline.
I have never used it, but it is on the word is
Racemic mixture.
combination with racemic epinephrine. Okay. And another thing what you can use is what the thing which
Heliox mix.
yes, the decrease the
Yes.
density. What is that?
Yes.
Heliox.
Helium.
The Heliox.
What
Heliox
is the
mixture.
what is the
Helium.
limitation with Heliox?
Cost.
Limitation. What is the limitation if you are using Heliox? You cannot give high FiO2 because it is usually 70-30 or 80-20. Okay. So Heliox, the problem, and it is for upper airway obstruction. Okay. It is not for lower airway obstruction. It is usually for upper airway obstruction. Okay. So what happens if you reduce the density? What happens? Why we say that it's better? Why? Because when density is decreased,
Reduced
flow become
airflow will.
laminar.
Yes.
Okay. Versus turbulent. It will not be turbulent. If density is more or resistance is more, then turbulence occurs. So that that is how you should be learning. You will all people will run away. Now you should be knowing at this time laminar versus turbulent. You should be knowing the factors which make laminar flow and turbulent flow. Okay. Okay. So actually this whole story is there in when we discuss about Strider. Okay, because I'm trying to cover pediatric anesthesia in as low time as possible. That's why I'm just covering the troubleshooting as well, because upper airway obstruction is a big problem in pediatric population. Okay. So if you know the concept about it, so you will be using it as actually it will be either infective, foreign body, or like inflammatory. Okay. So for infective, you need to give antibiotics. What is the example of infective cause of Strider?
Crew.
Epiglottitis.
Epiglottitis, not croup.
Bronchitis.
It is epiglottitis. Okay. Example of crew is inflammatory. Epiglottitis and infective, another word is tracheitis. Okay. And foreign body is foreign body. Okay. Foreign body can result in inflammatory response as well, but foreign body is foreign body. So the basic principle will be, some of the principle will be same. And if you want to treat Strider, your first evaluation will be on the basis of any signs of respiratory obstruction. Okay. And obstruction will lead to distress and then failure. Okay. So when you are dealing with it, the first thing is to rule out is whether there is obstruction or no. Then it will be resulting in distress, and it then when the compensatory mechanism will go bob down, there will be failure. So whatever they ask about Strider, the theme will be like this. If you are talking about foreign body, the foreign body, there will be, you have to focus about the history, that how much time has been elapsed, what is the history, and what is the nature. Okay. So and your main aim will be to, first of all, of course, see the level of respiratory obstruction, and your aim is not to make incomplete obstruction to complete. Okay. And in any like obstruction, and wherever you have any doubt, what things you always have to tell, your approach will be airway, breathing, circulation. You will be multidisciplinary team. Okay. You should have ENT, for bronchoscopy, rigid bronchoscope, okay, and they should be ready for tracheostomy as well. Okay, and you should not do any airway manipulation outside OR. Okay, unless emergency, you should not do it outside OR. You should take the patient to OR with all the gadgets. Only then you should touch the patient, because otherwise this, when the baby cry, or if you try to manipulate, this may cause complete obstruction. Okay. So if complete obstruction occur, you should have thing in your mind, Heimlich maneuver. Okay. They can ask you if they are asking in young, like infants, they can ask about this Heimlich maneuver. And sorry, not I'm sorry for being wrong. Heimlich maneuver is for adults. For pediatrics, you have to do this thrust, abdominal and thoracic thrust. Okay, you put your hands. Have you people might have seen in the BLS? Am I right?
Yes, sir.
Abdominal thrust. It's for adults. Sorry, Heimlich maneuver is not for pediatrics. And thoracic thrust. Okay, so this is the basic principle. If you are dealing with any airway obstruction, the other thing I have already told, if it is this one infective cause, you have to start antibiotics, and the rest of the things inflammatory, anti-inflammatory, use of Haliox, use of reciproc epinephrine, the concept of laminar versus turbulent, and what will you be doing after, what will be the ways of managing airway in this scenario. That you can have with the rigid bronchoscope. Once you did the inhalational induction, rigid bronchoscope, and you can attach through side port. Okay, but at the same time, when you once you have IV line, where you can have some TIVA, because why Memuna? With the rigid
Because
bronchoscope, yes.
because we inhalational induction, inhalational agent will not be
Unreliable.
we cannot make, yes, unreliable. We cannot achieve the MAC
Yes,
because
like we will there will be concerns related to it, that so you can augment it with some TIVA. Okay,
yes, we
so
use
this
TIVA.
is the reason. Once they have removed the foreign body, then you can actually you have number of options. You can pass endotracheal tube. Okay, and actually sometimes they use the fiber optic. Okay, to just see any damage. Okay, and in some conditions they do the lavage. According to the scenario, they can do some lavage, and you can use some steroids. Or
Yes, they can also inject locally steroids,
yes,
depending upon the situation, and
yes.
few
So
cryotherapies locally.
and some other cases you can have LMA just to maintain the airway. If they are sure there is nothing problem, you can maintain with LMA or even with face mask. It's according to the scenario. But usually these patients may be full stomach. Okay, because if it is emergency, the babies will be full stomach. So you think you should be considering the concerns related to the full stomach as well. Okay, so in this discussion we have actually covered a topic because we don't have too much time for it. We have discussed in detail, but the pearls I have told you about how to manage airway, how to manage any airway problems. Actually, the same problems will be in the post-op period as well. When you extubate the patient, again, you have to, the problems can be there. So you have to make sure, that's why you don't forget to tell about air leak and presence of airways, oropharyngeal airway, and try to extubate awake. Okay. Because if you extubate in light plane of anesthesia, there are exaggerated airway reflexes. Okay. Related to airway reflexes, which is what is the difference in from the adults? Maimuna, sorry, I mistakenly mute you. Please speak out. Unmute yourself. What is the difference?
Sir, airway reflexes, we try to extubate the kids fully awake because of the more problematic post-op airway complications.
No, no, actually,
And
I'm asking something else. Airway reflexes. Actually, for airway reflexes, there is two things. One is vagus and one is sympathetic. Okay.
okay.
So vagus is more pronounced.
Yes, parasympathetic system is so.
There is high vagal tone. So that's why if you have to choose between salbutamol versus ipratropium,
We choose ipratropium in kids.
okay, so you should choose ipratropium. Okay, the reason you understand, everyone understand this thing, because they have less developed sympathetic system. So ipratropium is anticholinergic. Okay, by the way, and
Yes, sir. We will
ipratropium,
target the parasympathetic system.
okay, so in addition to that, steroids and the other thing which we have already discussed. Okay, some people use the word ketamine to start with. Ketamine is bronchodilator. No, actually, remember one thing: ketamine or IV inhalational agents, they are bronchodilator. Okay,
Yeah.
but they are not the first things. You should be telling these things first: ipratropium, salbutamol, and then the core the thing. Just regarding few words, in pediatric population, it's not frequently used, but magnesium, lidocaine, okay, and the last resort when everything failed is ECMO. So whenever you are dealing this question of bronchospasm, this is also a question which is almost in every other exam it's being asked about. They may ask in the post-operative period, they may ask in the intraoperative period. Okay, so there are different ways to manage it, starting from avoiding the reflexes, blunting the responses, and then some things for membrane stabilizing, and for something for anti-inflammatory, and some things to as a core, like in resistant cases. Ketamine, if you give, there is bronchodilation may occur or will occur, but there is problem related to secretions as well. Okay, so you have to consider these things. Okay, so now we will come back. So we were talking about medications, because I think we have covered. Anything missed in airway?
Sir, I want to ask you a question about airway, especially the nervous part of the airway, pediatric airway, because I have read somewhere that the glottis is the nervous part of the airway in both adult and pediatric. This
No,
is the latest
no, no,
concept. Is it the
no, no,
way?
no, 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 no.
No?
It is not like that. I'm not sure about the age. What age you should just confirm it. The age when this is transition occur. This is for sure.
Okay. Okay, sir.
Okay,
Yes,
this
sir. There
is
is a transition. Initially, in neonates, the cricoid cartilage is the narrowest part. Then, with the passage of time, it turns into the glottis. Glottis becomes the narrowest part, and finally, in adults, the vocal cords.
okay. So just confirm, if someone just reconfirm the time, exactly time. Okay. Okay, so there are a few other things we will be now regarding the medications. The problem will be that renal excretion will be delayed. Okay, metabolism will be delayed, but blood volume is increased. Okay, so a patient might need initial high doses because of high volume of distribution.
High blood volume. Yes.
Okay, and high blood volume, but because of slow metabolism, the subsequent doses will be reduced. Okay, if you forget any other details, even if you know this thing, you can tell. Then another concept related to these medications is that in premature babies. Okay, first of all, this question answer anyone? What is the concept of post-gestational age? How to calculate it?
We will add.
When the
Yes,
baby present at theater at which age? Like 30 weeks, first month of age, and he has been had been born at 35 weeks. Let's say,
okay.
then it will be 65 post gestational age.
Yes,
We
like
have
the
to-
age at which the baby was born plus the age post conceptual age. Sorry, the age after birth. So, for example, if the baby is coming after was born on 30 weeks, and now the baby is 2 weeks old, so the post gestational or post conceptual age will be 32. Okay. So before, in some books it is written 50, in some books it is written 60. I don't know what is the correct one, but you can say 50 to 60 or 60. You can say there are chances of patients having this one apnea. Okay. So you have to avoid, or you should have to consider respiratory depression. For apnea, there are special apnea alarms. Okay. Another concept related to this thing is that no elective surgery before 60 weeks, 60 weeks post-conception. Okay. So this is the importance, and you then have to avoid long-acting opioids, like avoid morphine. Okay. In addition to this apnea alarm, what medication may be used or helpful in this condition? First of all, you have to monitor in HDU, apnea alarm. What else? Avoidance of avoid morphine. Then what else?
The duration of stay in
No.
post-op.
There is a medication. This may be asked in the exam, but it can come in MCQ as well. So
Sir,
what there is
caffeine?
a very good
IV
caffeine.
silent,
IV caffeine.
IV
Okay,
caffeine.
IV caffeine is being used. So this is how you should be approaching it. So in the main difference in medications that you have to calculate and dilute. Okay, another thing which is just related to, would you like to use 20 cc syringe or 3 cc syringe in pediatrics, and why?
For what?
So 20
Like,
cc syringe, since we have to use diluted drugs.
no, this you are not getting the correct answer. Just think in other way.
For what? 20 cc, 3 cc for what?
Actually, maybe I have not asked in a better way. I will rephrase the question. If you have,
Yes,
for
sir.
example, 10 cc syringe and you
Okay.
have 5 cc syringe or 3 cc syringe, which is better to use in pediatrics? Even if you dilute in 20, still you can use 3 cc, am I right? So this is
Yes,
not the answer.
3
Yes.
cc because
Please mute yourself.
sorry,
Yes, please repeat
sir,
again, Memuna.
because we also have limits and very
No, no, you are
accurate
not getting
calculation.
the answer. What is pressure? Pressure is force per unit area. Okay. So these pediatric people, usually the IV cannulas we are using is small, usually. Okay. 22 gauge, 24 gauge, for example, or even 26 gauge. Okay. So if you are using, for example, 20 cc syringe, you have to give more pressure. Okay.
Yes,
So it
sir.
is better to
Yes, sir.
use 3 cc syringe as compared to 20 cc or bigger syringes. This is one thing. Another thing is that, what is air embolism?
Accidental delivery of
Yes,
air into the
accidented
lungs.
air delivery. So usually it is more than 1 to 1.5 ml per kg. Okay. So maybe you are injecting a small bit of air, you don't know. But if you are using 20 cc syringe, can you accidentally inject some air?
Yes, sir.
Okay, and even you will not know because you are already pressing it. If you have a smaller syringe, even the bubble is going is very small. And this is more important consideration in the babies which have some residual fetal circulation.
Yes, and patent paradoxical air embolism. There is a risk of
PDA
paradoxical.
or
Patent.
VSD, ASD or VSD. Okay,
Yes,
so it
paradoxical air
can cause
embolism.
paradoxical air embolism. Okay, so one thing is dilution, that you have to dilute in a better way. Then you have to use smaller syringes. Okay, and you can use infusion pump, or you can use the microburette. Okay, because you have to calculate the fluid in a simpler way. So how to calculate the fluid? By 4-to-1 formula, Holiday Sikar formula. And what is the choice of fluid? The
Heat
most
solution.
notorious feed solution you will use.
Oh,
Why? I am using in Urdu as well as in English, haram. It is haram solution. I don't know why they are using it. It's a terrible thing. It has
yes, we
it
do.
has 0.18% normal saline. Okay, with dextrose. So what is the problem if you are giving low sodium? What is the problem?
Hypotonic solution.
Edema, cerebral edema.
Because these babies, they have limited concentrating ability.
Ability.
Okay, so they are already losing the sodium. So if you are giving a hyponatremia, they already have hyponatremia, and hyponatremia is a killer because of effect on cerebral physiology. Okay, so if you just say that potassium, magnesium and calcium are for heart, okay, and muscle, sodium is for brain. So this is, so how to treat? These babies are at risk of hypoglycemia as well, because of, what is the reason for hypoglycemia?
Due to
Metabolic rate is
No,
They have
gluconeogenesis in the liver.
no, limited glycogen reserve.
Glycogen storage.
Okay, if they have gluconeogenesis will produce glucose. So gluconeogenesis is not the problem. Okay, so this is not the, so they have limited glycogen reserve. Okay, so they can,
They have also this ability for gluconeogenesis due to immature or liver. Is it like your? Is
yes,
there
they have
anything like?
limited gluconeogenesis.
Yes, they don't have the because we are saying that the stress response. So they in the response of those stress hormones, they cannot produce that glucose level which
Just
is
tell me one
required.
thing in starvation. If you do think about starvation, which is the first store? The first store is glycogen
Yes.
or gluconeogenesis,
And lipids. Yes, yes.
or both of them. You can just reconfirm it. I cannot recall that. What is the first response? Is it the glycogen breakage or it is the new gluconeogenesis?
glycogen
Okay,
breakage.
I think glycogen breakage. Okay, so then new gluconeogenesis occurs. So I think in my concept, it is a glycogen which is more important. Okay, So now, because they have impaired liver functions and they are prone to become hypoglycemic, so you can do in that way that you can divide it in deficit and maintenance and replacement, continuous replacement, third spacing. Okay. So for deficit, you should definitely use balanced salt. Okay. Balanced salt will be either Ringer lactate or Hartmann's plasma light. Okay. Or normal saline. And this one you can use with 5% dextrose saline. Okay. For maintenance. And replacement it is better to have isotonic. Okay. So the basic principle will be balanced salt. Okay. So what is the most commonly asked question related to this dehydration or so that is the IPS, infantile hypertrophic pyloric stenosis. Okay. Who will tell what is the metabolic problems in pyloric stenosis?
It is
Metabolic.
hypochloremic.
Just a second. Just a second. Raise the hand and tell one person. Whose mic is creating so much noise? Who rose the hand, please? I cannot see it. Just a second. Okay, who? TAK, please. TAK, tell.
Yes, sir. Metabolic alkalosis.
Metabolic alkalosis only?
Yes, sir. That is the only one coming into my mind for now.
No. You know, there is a poetry. There is a poetry for pyloric stenosis. Yes, now Mamuna, you try. The metabolic problems. Huh?
Hypokalemic metabolic alkalosis. Initially.
Hypochloremic, hyponatremic, hypokalemic.
Hypokalemic metabolic alkalosis.
Metabolic alkalosis with, now the verse will be completed with paradoxical.
Paradoxical metabolic acidosis.
No, aciduria.
Aciduria. Okay, sorry. Aciduria.
Okay, when we have vomiting, we are using potassium, sodium, hydrogen, chloride. Okay. So there is dehydration. Is there any difference in vomiting in gastroenteritis versus pyloric stenosis? What is the difference?
So in vomiting and gastroenteritis, there's also loss of bicarbonate.
Very good. Okay. So there is loss of bicarbonate as well. Here, what is happening? There is excessive bicarb. There is too much loss of hydrogen. Okay. So the gravity. So what is the normal response in this condition? Now you continue, please, Mona.
So
What is the
kidney tend
response?
to remove bicarbonate to compensate
Aldosterone.
initial.
No, just a second. There will be a activation of aldosterone. So what it will be doing to increase the sodium?
Immune system will increase the absorption of sodium, and
decrease.
patient will decrease hydrogen. Sorry.
No, potassium. Okay. Potassium
Increase
mainly. So what
it
will
will
happen?
sodium to maintain a concentrated urine. So in worst condition, there will be it will explain aciduria. No. You are jumping. Just try to be a little slow. You are saying concentrating. No. If you are extracting sodium from the urine, it is diluted urine. So this is not the reason. Okay. This is not the concept. Initially, aldosterone will try to conserve sodium at the cost of potassium. But there will be a stage when potassium will be critically low. Okay. So now you have to sacrifice hydrogen for potassium. Okay. So this will be result in paradoxical aciduria.
aciduria. Okay. So why you are saying paradoxical? Because
if you have alkalosis,
Then you should have
okay,
alkaline.
you should conserve hydrogen, but
Yes.
you are doing it in the opposite way. You are crazy. I'm sorry, where is it gone? You have become crazy. Okay, so
Yes.
that is called as paradoxical aciduria. So now hyponatremic, hypokalemic, hypochloremic, metabolic, alkalosis with paradoxical
Aciduria.
aciduria. You know, we have verses sometimes, poetry in our anesthesia as well. So this is one of the poetry. Okay.
It's like that initially body is trying to conserve the volume status, and then ultimately electrolyte balance is the priority. So that is the
Yes,
reason of
yes.
paradox.
Yes. This is the reason which I have explained to you, that initially aldosterone is trying to conserve the sodium. Okay. But later on, it's not possible to lose more potassium. So that's why then it is in opposite direction. Okay. So when you are treating it, is it a medical emergency or surgical emergency?
Medical emergency.
Okay. So you have to
Surgical?
optimize. No, it's a medical emergency, dear. It's a medical emergency. Remember one thing, just tracheoesophageal fistula, congenital diaphragmatic hernia, infantile hypertrophic pyloric stenosis. All three are medical emergency, not surgical emergency.
Right.
Okay. They are not medical emergency. Surgical emergencies are something else. So you have to correct the dehydration. Okay. So it's another question which will be asked any part where. How to assess the dehydration status? Yes, please. How to assess the dehydration status?
We will take history from mother. Take it.
Okay.
Number of episodes of
Remember,
vomiting. We can
Dr. Mona, sorry to correct yourself. Remember one thing. In the this question will not be asked usually in the long case. Okay. This is a table viva question. So remember one thing, you don't have so much time that you will say this word, I will take the history from mother. No, you will use the word evaluate.
evaluate symptom and signs.
On the basis of history, examination, and relevant investigation.
Okay.
Okay. So how to assess it? What will be the pearls? You just have to speak out very quickly. Don't have time. Just try to practice in that way. What will be the signs? How will we quantify? It is 0 to 5%, 5 to 10%, more than 10%. Okay.
Sir, skin turgor, capillary refill, depressed
Just please let
continence.
her talk. Let her talk, please, Taimur.
Sir.
Just yes, Dr. Mona, finish. Try to finish it.
We will take skin turgor, fontanelle, eyes,
Mucous membranes.
mucous membrane, and then we will take vitals, pulse, blood pressure, urine output.
Pulse is important. Is blood pressure important?
No, sir, it will drop in later stages.
Urine output is important. Okay.
Yes, urine output is important.
Then
And then
lethargy.
or conscious level.
Yes, conscious level. And whether the baby is taking feed or not. This is a big sign in pediatric. Okay. So this is how you will be assessing it. And you should be knowing, I will show you the chart from where you can learn this thing. Okay. So now Taimur, now please take over, Taimur. You answer, how will you, for example, if I say 10% dehydration and the weight is 10 kg, how will you calculate how much fluid you will give?
So, sir, we will calculate the deficit first, and then
Just a
we'll
second.
give
I am sorry to interrupt, Taimur. Be a little loud. Be a little loud.
Sir, we will first of all calculate the deficit.
No,
the
I have told you
requirement.
the data. It is 10% deficit. And the weight is 10 kg.
Sir, I'm sorry, I don't know about this
There
answer.
is actually the answer. You just you that the answer is that 10 ml per percent per kg. Okay.
Right, sir.
This is the usual formula which is being taken. If you have 10%, so 10 multiply by 10. I put 10 to make it easy. So it will become 1 liter. So half you will give in 8 hours and rest half in
12 hours.
16 hours. Okay. So
16,
this is
maybe
usually
24.
it is like that. You will
Right,
not
sir.
give an, and you will make some goals. Okay. You will be evaluating any signs of overload. Okay. You can use anything, you can use ultrasound, clinical. Okay. You can repeat ABGs, electrolytes. Okay. Urine output. Okay. So this is how you will be, and that's I have told you that one is deficit, one is maintenance, and what about third spacing? Usually this is actually not related directly here. It is more important in abdominal surgeries. But what is the concept of third spacing? How you say that this patient needs 1 to 3 ml per kg, this patient needs 3 to 5 ml per kg, and this patient needs 5 to 8 ml per kg. How you
Yes, sir, on the basis of the scar, the incision.
yes, no. If it is superficial surgeries, it is 1 to 3. Okay.
Yes,
If
sir.
it is opening the body cavities like laparotomy, it is actually 5 to 8 ml per kg. Okay. So that spacing. Then another loss is insensible loss. What do you mean by insensible loss?
Loss by
Sir, the loss in the form of evaporation.
I'm sorry, please speak. One person speak, please. You just continue, Tamur.
Sir, insensible loss is loss in the form of evaporation or.
You know, your sound is coming very low. Please try to speak a little louder.
Sir, the loss in the form of evaporation.
Yes, sweating, respiratory, because we have dry gases. Okay. If you don't have the
Yes, sir.
humidified gases, then it will loss will be more. And then any drains. Okay. Urine output, any drains. Okay. So you have to, and then another very important point is allowable blood loss. Okay. So now, Memuna, you tell how to calculate the allowable blood loss.
Available blood loss.
Sorry.
Blood loss can be calculated.
I'm really sorry, Dr. Mucosa. I cannot hear you. You have to be a little louder if you want to speak out.
Saying available blood loss can be counted or calculated.
I again apologize. I cannot hear you at all. I'm really sorry. I cannot hear you. Maybe you are using the headphones. You remove the headphones and try to speak out directly to the phone. Yes, Memuna, please continue.
For allowable blood loss, we can calculate it by platelet or HB, I think so. I know two these formulas.
First of all, you have to calculate the blood volume and then
Yes.
initial hematocrit,
Yes, or hemoglobin,
allowable,
whatever.
allowable,
Divided
initial.
by hematocrit, multiply with blood volume.
Okay. So you have to calculate the allowable blood loss, and then up to allowable blood loss, you can continue with either 3 to 4 times crystallide, okay, or 1:1 of colloids. Okay. Which colloid is better? Is 5% albumin. It's not available everywhere. Then you have starch, hetasterol, okay? And then you have gelafusin.
Next is the
Sorry?
sorry, sir. Best colloid if there is blood loss. We should say blood. Is it like this?
Allowable, that's what I've told you. That before allowable blood loss. You will
Okay,
not
okay,
start
sir.
with blood immediately. Okay. So albumin is related to relatively less complications, though allergic responses can occur, but then hysterolil, gelafusin, and the worst is dextran. Okay. It is related to coagulopathy, platelet dysfunction, blood cross-matching issues. Okay. So that's how you will be fluid management. And actually, remember, I'm sorry for my very terrible handwriting. I'm not very good at writing with stellate. So fluid management is the most important thing. Assess and evaluate, whatever word you want to use, and then calculation of blood volume and allowable blood loss. Okay. And then for deficit, maintenance, and third spacing. Okay. So this is the basic concept of fluid management. If you have a premature baby, you can check the blood sugars levels and you can add 5% or 10%. Okay. According to the blood sugar. But the bottom line is that balanced salt is the choice. Okay. So we have up to covered the journal principles. Okay.
Sir, I have a
Airway.
question, please.
Yes, please.
Sir, you have written the estimated blood volume formula, which you have written is 85 to 90 ml per kg. But in case of neonates, please kindly correct me if I'm wrong. In case of neonates, isn't it
90 to 100.
90 to 100 ml?
Yes, it's absolutely right.
Right, sir.
Okay. Actually, you in different books, you will find different. Even in the exam, you have to be very, in MCQs, of course, you need to be very pinpoint. Okay. But in Viva, you can be very smart. Okay. You can say usually in adults, it is around 60 to 70. In younger babies, it is up to 80 to 90. And premature, it is even higher. Okay.
Right, sir.
So we have up till now general principles, airway, fluid, some emergencies. Okay. And I don't know what is left.
So, sir, started
Yes.
the movement, we can start like if 10% isn't not included in shock. So initial fluid bolus or 20 ml per kg of crystalloid.
Just tell me one thing. If you have a dehydrated patient, okay,
Yes.
would you like to give a diuretic fluid?
Diuretic fluid?
No, sir.
Yes. 10% can cause diuresis.
I'm not saying 10%. I am saying that you said that there was the 10% fluid deficit. So I am saying that from initial management, we started. You said that baby is lethargic, not taking anything orally. So the first isotonic crystalloid 20 ml per kg.
Not 20
With
ml. 10 ml.
20 ml per kg. No?
Actually, your voice is again distorted, Memuna. So actually, I will repeat. You will try to understand. Just a second. Just mute yourself because there is a lot of sound coming. So the concept is that actually there is no fixed rule. This is actually practically it is academic only. Practically, you will assess the dehydration. That yes, it is severely dehydrated, and accordingly you will start the fluid. And then you will see the response and you can increase, even if you if you do the PALS PALS, Pediatric Advanced Life Support, you will see that they have written 10 to 20 ml. So you can increase according to the response. Okay. You can decrease if you started with 20 ml per kg and then you see the response. This is the total calculation of the fluid. That if you say that this is 10% dehydration in a 10 kg, so it will become around 1 liter. So you have to give around 1 liter of fluid in next 24 hours. And the initial speed you can start and in a higher, and then you will titrate according to the response. Am I right? Am I right, Maimuna? Now you understand?
Yes, sir. But in the shock, we give bolus within 15 to 30 minutes or according to condition of patient, right?
According to the condition of the patient. You already
So,
say.
so when we talked about the maintenance fluid, so baby is okay now, and I want to maintain fluid because baby is NPU, right? Because
Yes.
he's having. So for the maintenance fluid, what that will be 150 ml per kg per day or per 24 hour, whatever the way.
No, 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 no,
But
no.
no.
No, no, no. 150 ml. No, no, not at all. You calculate the maintenance fluid with 4-to-1 formula.
4 to 1 formula.
So 10
So
10 kg will be 40 ml per kg per hour.
per kg per hour. Okay, that is also fine. So the fluid will be with the 0.4% half saline with, you said 5% dextrose, and we will add KCl, right?
No, not necessarily. Listen, you can continue the deficit with the, because if you have a dehydrated, unstable patient, still you have the, in the first 24 hours, you need to replace that fluid, dehydration. Am I right? So there will be two different fluids. One is maintenance.
Okay.
And the other is replacement.
Okay.
Or deficit.
So in maintenance fluid, I will add KCl as well. 10 millimole per 500 ml and according to serum potassium levels, right?
Listen, remember one thing. If you are giving a balanced salt, you don't need to add anything. If you are using, for example, lingual lactate or plasma light, unless there is documented hypokalemia, you don't need it.
Okay.
You are mixing it up with DKA, I think.
No, I just read it from, I think so, the BJ
Remember
article.
one thing, be very smart. Don't try to reproduce, just be a conceptual. Just tell me in any patient without documented hypokalemia, would you like to give any potassium?
No.
Okay, so that's the answer. Okay, so, I think we will stop here. And I just try to cover as many aspects of pediatric anesthesia. So any questions? We will need to have another session for rest of the concept, because today I will have some more time. If I don't receive any call, I will send the link at the same evening time, which we have is 10 p.m. Pakistan time and 10:30 p.m. India time and 8 p.m. Saudi Arabia time. Okay. So if I don't receive any call, I will send you the link and we will finish the rest of the important concept of pediatric anesthesia. As I showed you here, please, you can subscribe to the channel as well as, and this playlist, you will find it for pediatric anesthesia as per as your availability of time, if you listen it, and anyone can ask any question anytime. Okay. So I have discussed all these topics before. Majority in the later part is in English. Initially, it was in our native language. So you can get benefit, and inshallah, we will meet again. Thank you.
Thank you, sir.
Any questions?
No, sir. Thank you.
And
There are some
at the
questions on
last,
the chat.
yes,
There are some questions on the chat. If you could answer them.
Yes, please. You are welcome. Please tell.
I'm saying there are some questions we have put on the chat, the name of the YouTube, so that we can subscribe and follow.
Yes.
Thank you.
Are you following my WhatsApp group? Are you in the WhatsApp group?
I'm not on the WhatsApp. I'm not on the WhatsApp group.
Okay, just do a
Maybe
favor,
you can
note
put
down.
it.
Yes, note down my number and just send
Okay.
me a message with your name. I will add you to the WhatsApp group. Okay. Just note down this number.
Okay. Okay. Yes. Mention.
5830-33118. Okay. And
Repeat.
it's written in the chat.
Okay. Let me look for it.
Just
Okay.
drop a message on WhatsApp with your name and I will add to the WhatsApp group. This is one thing. The name of channel is Anesthesia Knowledge. Okay. Anesthesia
Okay.
Knowledge. This is the channel.
Thank you.
And another thing is that, you are from which part, where are you residing at the moment, Dr. Jackson?
I am in Uganda.
Uganda. So you see, we are so
Africa.
lucky to have people from Africa. And what about the Dr. Kule Gooden? You have raised the hand, please.
Yes. I'm also from Uganda.
Yes. So we are very lucky to have people from that part of the world. And you are more special to me. Okay. So because I have been for a diploma exam in Dubai, and I encountered some of the people from African countries, and I really salute to you people that you are working in such compromised state. Okay, so you are
Yeah.
much more special to me, and whenever you want any help, you all are welcome. Okay.
Thank you.
And one day I would like to come to Uganda to dance with you in your
Oh
traditional
yes,
style.
you're welcome.
Okay.
Welcome.
Sure.
Yes.
Thank you.
Oh, we shall be so grateful to meet you, sir.
Yes. Okay. Thank you very much. Bye bye.